Yep. Okay. What I decided to do today is this is a workshop. I got back from last Saturday from California at the iBank meeting. And this is a presentation that I give to young people or people who are just starting out doing iBank, talking about the importance of the corneal endothelium. And what is important about this is that I don't know much, because you have a diversity of backgrounds here. I just wanted to bring you up to date as what we know about the corneal endothelium and why in Fuchs patients the corneal endothelium decompensates. And so really what I'm going to do in the time here is to go through the importance of the corneal endothelium, specular microscopy, a little bit about that. This is the way we can look at the endothelium and see what's going on. And with the new instruments that we have available today, you know, you can actually get pictures of your endothelium, and your ophthalmologist should be able to do that and give you these pictures. And I'm not talking out of turn because that's something that everybody should have is a specular microscope, so when you go see your ophthalmologist and they look at your cells and say, gee, what's going on? Can I have a picture? Then you just print it out, push a little button. And don't be afraid to ask them. Okay, so what do we do with the cornea here and with this? Well, one, we want to spend a little bit about the structure and function about the endothelium. We have developed ways to store corneas now, which we never had before. I'll give you a little history of this because one of the first person who really started getting into taking the cornea out from the whole globes is Bernie McCary, and Bernie is over in our faculty at Emory, but he was my first graduate student, and when he worked with Herb Kaufman, they decided to do this. A little bit about the viability of it, some endothelial images, and then we'll look at the endothelial cells from what we can see in the laboratory. So this is a very simple diagram of the cornea, and I want you to kind of think about this, and this is what the ophthalmologist looks at when he looks at a cornea when you sit in front of the slit lamp. He's actually giving you a cross-section of the cornea, and this is what he's looking at with that thin slit of light. We have the corneal epithelium, which is roughly only about 5 microns, 50 microns, and this then is covered obviously by the tears. And then we have this large stroma here, which is transparent. And then we have, of course, the corneal endothelium, which is the topic for this morning. And then we have the aqueous humor. Okay, now what do we know about that cornea? How thick is it? The thickness of that cornea is 500 microns. Okay, now what is 500 microns? How do you put that into a rule? Okay, we all know what a ruler looks like. Well, sometimes we work, you know, in the metric system. So if you have a ruler that's in inches, and then you have a ruler that's in the metric system, and each ruler, little dot on a ruler is 1 millimeter. Okay, that's 1,000 microns. So it's half of one of those tiny little sections, 500 microns. Now, why is the cornea 500 microns? Well, the main reason is that, you know, this is something that we've learned, is that the maximum distance that oxygen can diffuse from the atmosphere to the endothelium is 500 microns. In the lung, you're breathing, you're exchanging CO2 and oxygen, and the maximum distance that oxygen can diffuse is that 500 microns. But where does the corneal endothelium get all its oxygen from? The atmosphere. So that, you know, so it's not by chance. Also, the cornea here is, with this thickness, transmits up to 93% of the incident light. So there is some absorption of the light because we have the nuclei up here in the corneal epithelium, and then you have these little keratocytes here that all absorb light. But so 93% of that light goes across the cornea. But when the corneal endothelium starts to decompensate, what happens? The stroma swells, becomes edematous, takes up water, and then it starts to scatter light. So, for all you ladies, I want you to think of the cornea as we look at it is a piece of student crystal. You know how clear it is. Okay, and a cloudy cornea, which is edematous, is like milk glass, white. So, okay, and what regulates that? The corneal endothelium. Okay, so let's look at this in a little further depth. If we get a cornea and we send it to the histopath lab, and we look at it from what the structure looks like, this is what it looks like. Here's your corneal epithelium, and here's the stroma. And then, of course, if we look at the endothelium, this is what the endothelium looks like on a histopathological slide. This is a very, very good endothelium. It has a high density of endothelial cells. Okay, it's this layer that we're going to be talking about, and particularly in Fuchs, where we have some changes that occur and the cornea endothelium eventually gives out. Well, what about this cornea? What's so different about it, or and what's normal about it? Well, what is the cornea? It's made up of 78% water. And then it has collagen in there. I mean, we see collagen in our skin and everything. And it has a bunch of other protein or proteoglycans, which we call keratin sulfate and chondroitin sulfate. And these are very important components because they act as spacers for the collagen. Because don't forget, we don't want that cornea to scatter any light. So when we think about the corneal endothelium, and we think about Fuchs, and we think about the people working in the eye banks who are getting corneas from donations, and then they're putting them into a media, what are they looking for? They're basically looking at this corneal endothelium. They want to see what the cells look like. We want to find out something about the junctions here, because that's what holds the cells together. And then what really makes the endothelium work is that there's an enzyme there, which we call sodium potassium ATPase, and this acts as what we call a metabolic pump to dehydrate the cornea. So this is what the corneal endothelium looks like. And so when you go to the ophthalmologist and they look there, and they look in there, you can get this with a slit lamp, but he should be able to use a specular microscope, and you'll see a picture like this. And so what's important about this? Well, we look at the cell number. This is a relative good 2,900 cells per millimeter square. One of the things that eye bankers think about and everything is that when they send a cornea out for transplant, they want to have a cornea that has cells, at least 2,000 cells and above. That's a very important point because they're putting in a new population of corneal endothelial cells. And then we can do a lot of other things, is that we can look at what the hexagons look like and the coefficient of variation. And this tells us a little bit about the state of the corneal endothelium. And this is why it's important for you as Fuchs patients that this data be put into your record. We want to know, what is your cell count? That's important. And you also want to know that too. And don't be afraid to ask the ophthalmologist, because he should be able to give you that. I'm looking at Dr. Lee here and he's saying, oh, should I be given that? Yes, he should. Because this is an important thing, because this tells you where your corneal endothelium is in terms of, well, is it going to decompensate or where we are? Well, what does the corneal endothelium do? Three basic things. One, it serves as a wonderful barrier to prevent the fluid from the aqueous humor from leaking into the stroma. And it serves as a metabolic pump because you want to keep that cornea in a dehydrated state. And if it does that, a cornea maintains itself transparent. So that's the goal, and that's what the endothelium does. So let's look at this a little bit further. And don't forget, what you're talking about, I mean, many are here because of what we call Fuchs endothelial dystrophy, where the endothelium is given out. And there's a genetic component to it, but really, the function of this endothelium is quite simple when you think of it. It has these little endothelial cells that stick together, okay? And then it also has this metabolic pump. So if the pump can balance the leak. The cornea will maintain itself at 78% water, maintain its thickness, and be transparent. Okay, so what happens as we go through, and I'll show you in Fuchs, is that this balance changes. Because in many cases, with our Fuchs patients, the pump can't balance the leak. So what happens, the cornea swells up and gets edematous. Starts to look like that milk glass that I was talking about. Okay, let's look at this a little bit further from a diagrammatic point of view as we look at the corneal endothelium. So we take these endothelial cells, here we are, here's the pump, and the barrier. Well, what is the barrier we talk about? They're tiny little tight junctions that go through here. And these tight junctions right here keep the cells together. Now the corneal epithelium also has tight junctions too. And the tight junctions in the epithelium play a very important role because that's why bacteria can't get down into the cornea, into the stroma of the cornea. And that's why in cases where there's some trauma to the epithelium and everything, that we deal with corneal infections. So these tight junctions play an important role. They keep the cells stuck together. And then we have this wonderful enzyme called sodium potassium ATPase, which will then pump water. And basically, I'm sure you've all had grandkids and kids where you've taken a piece of celery, you take a piece of limb celery and you stick it in a glass of water. What happens to that piece of celery? It gets stiff, right? That's okay. This is osmosis that's going on. So what this metabolic pump does in the endothelium is that it will, what we call, actively move sodium ion out. And as it moves the sodium ion out, it osmotically takes water with it. It keeps the tissue in a dehydrated state. 78% water, 93% transmission of light through the cornea. Now, what do we know from a very lovely lecture that Signe Maximous had given a number of years ago at the Jackson Memorial lecture at the Academy? He showed that, one, we're actually born with roughly, we have, maybe about 3,000 cells per millimeter square. Roughly, the corneal endothelium that we talk about has between 350 and 500,000 cells. Okay, with minimal amount of cell division. So there's once they're damaged, they kind of don't replace themselves. So what we know is that when a cornea comes, or when they say that it's time for a corneal transplant, we know that that cell density has dropped down somewhere between 400 and 700 cells. So we have a tremendous physiological reserve of endothelial cells that will help us from intraocular surgery, trauma, and disease. So this is why it's important that you know, what is my endothelial cell density? Are you up here, or are you down here, or are you somewhere in the middle? And don't be afraid to ask your doctor, because that's important. And they should be able to tell you. Okay. Because we have instruments now that can do this. All right, so here's a good example of two pictures of corneal endothelium. And this is what the eye bank deals with. We all say, well, if you're going to have a corneal transplant, you want a young tissue. Well, that's usually the right case because they have many more cells. But here's the tissue that came into the eye bank. 35 years old, only has 1,200 cells per millimeter square. And here's a person who's 65 years old, has 2,900 cells per millimeter square. Well, obviously, if you're going to have a corneal transplant, this is the tissue that you want to get rather than this one. So endothelial cell density is very important for eye bankers too, because when they send out send out the tissue in the Optisol, they're going to give the doctor a report of how many endothelial cells are there. And certainly Bruce will be able to verify this when he talks a little bit about from the eye bank. Okay, now let's just think about this with that endothelium. There's a longevity to it. Remember, 3,000 cells, 400 cells, and we have this big physiological reserve here. So normally the endothelial cells age themselves at approximately 0.5% per year. So you've got a population of endothelial cells that'll last you 200 years. But what happens in Fuchs with this is that the aging process increases, and you may be losing cells at, say, 2% per year, maybe 3% per year, and you can see how the longevity will decrease. Again, ask that doc for that endothelial cell number.
That kind of explains why if you get it younger, if you have symptoms younger, it's accelerating faster.
Exactly.
Like in my case, my symptoms were in my early 40s, and I needed a transplant when I was 50. And other people might not see it until they're 70 or 80, in which case they may never need a transplant because the progression is like 2%, and mine's like 3%.
Right, exactly. And then, by the way, if you have any questions I'm talking, this is, we want you to get the most out of what we're going to talk about. So
we're trying to save questions
hand.
for the end, but then,
No, that's all right. So realize there is a longevity, as you see through here. And this is, and I put this up because this is where some of the Fuchs patients, because they do lose cells faster than other people. So if you look at that balance of where we are at birth, say we have so many 3,400 cells per millimeter square at birth, and we know that corneal decompensation occurs at 500, so that gives us a very, very large reserve of cells.
Doctor?
Yes?
I've heard that it's more important the quality of the cells rather than the cell count itself.
Okay.
Well, I think it falls into both. I think that there is the quality comes in terms of what the cells look like. In other words, if they're perfect hexagons, we know that quality of endothelial cell is better than a cornea that has a lot of big and small cells. So that plays an important role, yes. But still, cell number is so important, because when you put a cornea in for a transplant that has a higher cell number, you have a greater density of cells that can spread out to cover the defect of the other area. Now, there are some unusual things about endothelial cell densities, and this might be kind of interesting, particularly from our friends from California here. I had a fellow from Osaka, Japan, and when I was up in Milwaukee, we looked at endothelial cell counts from a number of, basically a Caucasian population here. And you can see that there is an aging phenomenon as you go from 20, 40, 60, 80, that there's this slow decrease of endothelial cells. But we also had access to a population in Osaka, Japan, and if you look here, they have many more cells than a Caucasian population. So a person in Osaka, Japan, who's 80 years old, has as many corneal endothelial cells as a 20-year-old Caucasian. Very interesting. We don't know why, but we also know that Fuchs endothelial dystrophy is not a big issue in Japan. Because I can remember Dr. Dolman, who was up in Boston, prepared this wonderful lecture, went over to Japan to give it, and was going to talk about Fuchs endothelial dystrophy. And after he gave the lecture, it was kind of quiet, and then somebody came up to him afterwards and he said, Dr. Dolman, we don't have Fuchs endothelial dystrophy here. So I think this gives you an issue of some genetic component here to it, which we don't know that about. And we have to, and actually the people up at Hopkins, John Gosch and his group, have actually been looking at some of the genetic components of Fuchs.
Are Caucasians the largest group of endothelial dystrophy?
Pretty much, yes. Yes,
We're in the right room.
Yeah, right. We're here.
You were going to say something about Californians?
Well, I say this in California because you do have a large Asian population in California. So eye bankers are especially concerned about this than in California because of the donations of tissue. And it's not unusual to get a cornea that will have something like 400,000 cells per millimeter square. All right, here's another example of the endothelial cells that eye bankers face. They may end up getting a pair of corneas that come in, and they're looking at this, and it may be from a young person. And this is the right eye up here. And you say, gee, here's this, look at the density of this cell, this endothelial cell. And look at this one in the lower panel here. This is the other eye. This is the left eye. Well, this one certainly would be sent out for corneal transplant. This one wouldn't. And basically what happened in this eye, this was an eye that ended up having a considerable number of infections over the period of time, iritis and everything, and it lost many endothelial cells. But I also think this shows a very other interesting. This is how the endothelial cells age themselves. Notice high density and the low density here. See how the cells, you lose cells, the other adjacent ones spread out to fill the defect. And then when that cell density gets down to 400 to 700 cells per millimeter square, then the corneal stroma becomes opaque. All right, now what's important about this from the surgeon's point of view? Dr. Lee and Dr. Kazarski, they're going to go up and talk a little bit about cataract surgery and things. Well, what's so important about this is that if you take a human cornea, from any person, and the epithelium is damaged, it's only going to swell a little bit. It's going to swell, say, from what that level of 500 microns, it'll swell up to 700 microns. However, if the endothelium is damaged and you start to lose cells like in Fuchs, what happens and why you have to have a transplant is that the endothelial cells, if the endothelial cells are damaged, will swell from 0.5 millimeters up to 1.3. So it's this tremendous amount of swelling that occurs in the posterior part of the cornea. And that's related to these proteoglycans that are there. So there is this differential swelling. And of course, if the cornea swells that much, it's going to become opaque. All right, let me just show you a few very interesting things of how phenomenal the corneal endothelium is. A number of years ago, we were very much interested in seeing, well, what about this metabolic pump? What's so important about this pump that keeps the cornea transparent? So we worked with the eye bank, and we got 28 pairs of eyes. The mean donor age was 58. The age range from 11 to 91, and from death to where we did the experiment was 21 hours. You know, this is really wonderful eye banking time. And then we looked over these from the age. You can see that slow little decrease of endothelial cells, which is normal. And we find out with that slow little decrease in endothelial cells that we were able to measure the pump sites. How many pumps are there? And it didn't change. Now, what was very interesting in this is that we also got or received 6 pairs of corneas from patients that had Fuchs endothelial dystrophy. And of course, look at the endothelial cell number compared to the other one, a little bit lower here. And what was unusual about this is what the endothelial cells look like. This is the normal, and you can see these little black spots here. This is what we see in patients with specular who have Fuchs. Now, and this is why you can see cell density. But notice, we were able to take this picture, so the cornea was clear. It was transparent. So even though we had these abnormalities, which you see these little black specks here, the cornea was transparent. Now the reason the cornea shows up as black spots is that the only way we can see these corneal endothelial cells is the refractive index of the endothelial cell is different than the refractive index of the aqueous. Okay? But when the cells are spread so thin that refractive index is nullified, you don't see it anymore, and it shows up as a black spot because they're thin, the cells. Well, anyway, this is a transparent cornea, the lower one. And what did we find with that? We found that in the early phases of Fuchs, that corneal endothelium can adapt it makes more pump sites. So as the leak increases, it makes more pumps, because it has that tremendous capacity. And then you say, well, how many pump sites are on an endothelium? 2 million pump sites. So these cells are working hard and really do. But they have this wonderful ability to adapt. And so that I think is a real positive aspect. All right, well, let's put this all a little bit all together from a diagrammatic point of view. Normally, we have this leak rate as illustrated in the yellow, and so many pump sites illustrated in red. And then in patients who have Fuchs, which we know from some of the tissues we receive from the eye bank, you get these big bumps in there, this guttatum. See how thin the endothelial cells are here? Well, as the leak increases, the pump increases, so the pump can balance the leak. Well, eventually this gives out. That's the whole bottom line that we deal with Fuchs. Well, what's the driving force of the cornea? In other words, you know, everything in the cornea to maintain that transparent, like that Steuben glass, we somehow have to have a driving force. What's going to remove the water? It's going to have to be something like osmosis that's going to remove the water. It's the only way things work in the body. And so we were able to take some corneas we received from the eye bank, and we could put a microelectrode in here, and we could see it into the stroma. Here's the epithelium, here's the endothelium. And what's important about this, the reason the cornea maintains itself thin and transparent is that it has that nice endothelium, as illustrated here. But the reason it's transparent is that the concentration of sodium ion is higher in the aqueous than it is in the stroma. So if the concentration of sodium is higher, then where's the water going to flow? It's going to flow from here to here. You all with me? See where this goes down? Okay, so you can see the importance of the corneal endothelium. That aqueous humor concentration is sodium, so water is going to go to the higher concentration to dilute it out, to get a balance. And that's where that endothelium plays an important role. Now, what happens when the corneal endothelium decompensates, where we lose so many cells? I've tried to diagram this here, where you lose some cells. Then what happens? This barrier is broken down. The water can move from the aqueous humor into the stroma. The sodium ion can move there because there's a higher concentration here, so more sodium can come in here, and then also the sodium that is part of these proteoglycans can come in there. So the sodium ion then is concentrated more in the stroma than in the aqueous. And where's water going to go? It's going to go in the other direction. So this is what's happening as in Fuchs as you go through. As you lose endothelial cells, the cornea stroma becomes more cloudy because it's taking up more water. So the only way then to restore that in the early phases, you use steroids. Steroids tighten up the junctions. We know that. That's one of the ways. But so if the swelling occurs so much, then a corneal transplant is going to be necessary. To go through that. All right. What do we know about how the endothelial cells repair themselves? And we know that in humans and in primates, that the only way the endothelial cells can repair themselves is by sliding over. So if the endothelial cells are lost or damaged, the adjacent cells slide in. In some of the animals, like rabbit, for example, the cells actively can divide. So when a corneal transplant is done, you're putting in a population of good endothelial cells, which then can slide out into the periphery and cover the damaged area. Well, there's more research that we know. If you look at this whole corneal endothelium in a pool like this, we're we're starting to realize the fact that we've always thought that this little endothelial cell, see it right here in the middle? We thought that that was going to last you 100 years. I don't think this is the case anymore because we've learned a lot. You know, and I certainly contributed to the dogma in my 35 years of research that's saying endothelial cells don't divide. Well, there is some division, but where is it? It's way out in the periphery. So think about this now. Here we have this cornea. It's a big dome, and we have these cells in the center here. So there are potential areas out here called the regenerative zone, which we think are adult stem cells. And so this may be one of the phases where, and I think as we go in Fuchs research now, we're going to have to look out in that periphery and see what's going on in those cells there. How the genes changed in some way. Because that's where the cells are slowly generated. So we have this high density of cells way out in the periphery, then we have a storage zone, and then everything migrates inward. So that's the magic that we're going to have to find out. And within the next 5 to 10 years, we're going to know what's happening out in that periphery. So the basic area is, think about this when you do a corneal transplant. If this is the whole cornea, a button is going to be made, about 8mm button here. And so you're going to be putting just the population in here. And these cells don't have the potential to divide as those cells out in the periphery. So something is happening out here in the Fuchs patients, and we just have to find out more about what's going on with those peripheral endothelial cells. All right, so let's kind of put this all together a little bit here. If you don't have the junctions to hold the cells together here, there's going to be no barrier, and there's going to be no pump function. So what's going to happen? The cornea is going to swell. Okay? So normally, with a good population of endothelial cells, we have these wonderful little tight junctions that stay together like this, and we have this enzyme here. And so, and don't forget, the reason that the cornea is going to swell too, because inside the eye, there's a pressure. 15 millimeters of mercury pressure, which is going to want to force water through those endothelial cells anyway. So you have to have something to balance that out, and that's where the pump comes in. So, one, the pump can balance the leak. And under endothelial stress, which happens in Fuchs patients where you slowly lose cells, there's this tremendous adaptation that can occur, where as the leak increases, you can make more pump sites, and again, the pump can balance the leak. And this is somewhere between 800 and 1,500 cells. That's why that cell density is important. But eventually, what happens, the cornea is going to decompensate. If you lose so many cells, as illustrated here, the cells are spread so thin. Remember all those little black spots that I showed you on the speculum? Okay, they're spread so thin, there's not enough room here in these lateral spaces to put the enzyme for the metabolic pump. And in this particular case, then, the leak is greater than the pump, then the cornea swells. So this is really the basis of what's happening in the cornea and what happens in Fuchs patients as they slowly lose cells, and why the cornea then will swell and take up fluid and become opaque. And of course, and because we haven't learned the technique of getting those peripheral cells to divide and slide in, we can't get those cells to multiply. And the other point is the eye is put together so that you don't want cells in the eye dividing, rapidly dividing. Because one, if they rapidly divide, it can plug up what we call the trabecular meshwork, the outflow, and then the pressure can go way up. So that wouldn't be good either. The lens has a nice way, you know, if we all live long enough, we're going to have cataract, we're going to have cataract surgery, for the simple reason that the lens is surrounded with a capsule. But the cells are dividing inside, but the cells can't get out. So what happens with age? Lens get thicker, 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 and thicker. But we've packed all those cells inside. Okay, now let me just show you some things. We know now that there are a large density of endothelial cells out in the periphery. If you look here, out in the center, and you go 2 millimeters off center, there's a 5% increase. And if you look way out in the periphery, a 10%. Now, hopefully, we're going to be able to get these docs to say, not only can I give you an endothelial cell density, but I can give you a peripheral endothelial cell density. Because that's where the action is going to be. And that's the type of information that you hopefully will be able to get. And just to show you where if we look way out in that peripheral area, look at this is way out. Look at the density of these cells out here. This density of this human cornea has a density of 6,000 cells compared to a central region of 3,700 cells. That's a 40% increase. So those cells are way out there in the periphery, and they're slowly migrating in. And the other thing we know, too, is that the superior region, the upper part of the cornea, has the highest density and then compared to the central area and compared to the nasal and the inferior region of it. So we know that those cells have a high density out there. Now, let me just show you in this graph, and then we'll think, is that we were able to get a lot of corneas from the Georgia Eye Bank, and thanks to Bruce Farmer and his group here. And we measured the endothelial cell density way out there. And notice here, see how the slow decline in the center? And this is the paracentral and the peripheral. So all of these cells are kind of aging, but you still keep that density of cells high in the periphery. So something is happening as we start to think about Fuchs endothelial dystrophy, is what's happening out in that peripheral endothelium. We've got to find out more information about that. Just to show you that in the rabbit cornea, if we make an injection in rabbit cornea, see these little black spots here? We can use various types of chemicals. We know they divide. But we've also been able to get human corneas where we've kind of wounded them a little bit that we got from the eye bank, and we took 35 pair of human corneas, put those dyes in there and say, are those cells able to divide? Only 7 of them showed some division. So they're reluctant to divide out there. But that's a good thing, because you don't want them randomly dividing, because then you're going to plug the trabecular meshwork. So there's a hint that those peripheral cells can do something and divide. And that's going to be the key that's going to open up and really understand the basis of what's happening in Fuchs endothelial dystrophy. And these show you, these are some of these human endothelial cells that can divide. But they don't want to do it routinely. It's not like a tissue where you cut your skin, you'll have cells dividing, or if you damage the corneal epithelium, the cells out in the periphery will have the capability to divide. Let me just show a little bit from the eye bank, and then we'll sit down and we'll have some other people get up and present. One of the important things when the eye banks go out was to understand how to keep endothelial cells alive. And, you know, I started out in this field to do an eye research when the eye banks with Allison Braley at Iowa started this so many years ago, and everything was run through ham radio operators where people would donate their eyes, and they would have to have within a 24-hour window to be able to do a corneal transplant. Well, that's no longer the case, because we have a wonderful window now of 10 to 15 days before we do a corneal transplant. We looked at a large number of corneas. Again, thanks to the Georgia Eye Bank here. corneas that are in Optisol. This is the way a cornea comes to the doctor when he does a transplant. And moist chamber, the way they used to be. Now, what is the difference? Moist chamber would be is that when a person dies and the eye bank goes and gets the eye, they enucleate the whole eye. They put that eye in what we call some gauze in a little bottle. And then when the eye then gets to the operating room, then the surgeon there will do his tree finding at that particular time of that, and then do it on the host. So it would be just with the whole eye. Well, this is all now done in the eye bank with Optisol. And the importance of this was that all these dots on this graph, this is percent damage in days in storage. You can see here that by 2 days, if you kept an eye in a moist chamber, 40% of those endothelial cells would be dead. So that's why in the early phases of corneal transplantation, everything had to be done in a 24-hour time frame. So thanks to the studies that were done by Bernie McCary and Herb Kaufman, they said we have to be able to get that cornea out of that eye and put it into some type of medium. And through a series of investigations that have gone through, we have a good medium. And that media will keep endothelial cells alive up to 20-some days. And that is the media that is being used now. So that's why corneal transplantation now can be scheduled. So you can, say, well, I'm going to have surgery on Thursday, and the eye bank can then supply a cornea to you. Because we have this wonderful way now of keeping corneas. This is what these endothelial cells look like. When the eye bank looks at some of them, you can look here. These are endothelial cells that are damaged, but all these look really very nice. And we can need to go through the graph. And just to show you here what happens with the endothelial cell damage. These are pictures taken of human corneas. And if you go up to 5 days in that Optisol, notice, or not in the Optisol, in moist chamber, notice the large degree of damage that occurs. But it doesn't occur with the Optisol. So eye banking has gone a long way in terms of supplying good tissue for you all. And here's a picture of what we're looking at from an eye bank point of view. These are corneal endothelial cells. That's a great population of cells. This is one that would not be transplantable because of the damaged endothelial cells that you see here with these red spaces. So the goal of eye banking then is to supply the best corneas possible for keratoplasty. And this is where cell number becomes an important point of view, because the eye bank is not going to send out tissue that have cell numbers below 2,000 cells per millimeter squared. Because they have to get enough population of endothelial cells so that can spread out and cover the area. And you can see with the corneas that are in Optisol with this, you can store these corneas up to 20-some days. And the endothelial cells are fine. They work. Now, many of our docs in the United States, they don't want to use corneas that old, but where do those corneas go? They are sent overseas and other people can use them. But they do work for keratoplasty. Okay, I think that I've covered enough of this from a basic point of view, but I just wanted you to understand the importance of endothelial cells, the number, and how those endothelial cells work, and what happens when the cells are spread out so thin that the cornea decompensates, and you have to have a corneal transplant. And we have a few more minutes here. Maybe if there's any questions, I'll certainly be glad to answer them. Yes?
You seem to touch on two subjects. Is there anything you can say about the interrelation of cataracts and glaucoma with Fuchs syndrome?
Well, we do know that glaucoma decreases the cell density. The same way, now one of the things with glaucoma is just the pressure in the eye has an effect on decreasing the ganglion cells in the back of the eye. It also will decrease the corneal endothelial cell density too. So a person who has Fuchs and has associated glaucoma has a much greater chance to lose endothelial cells. Similarly, a patient who has Fuchs endothelial dystrophy and has cataract surgery, then you depend upon that ophthalmologist to do a really good surgery with minimal amount of trauma, because we don't want to lose any other endothelial cells. So that's the relationship that we... Other question? Yes, sir.
Pump efficiency. If you have a 800 micron cornea pre-surgery, new endothelium cells go on. How long should it take to get back to normal, whatever normal is, 500, 550?
In other words, the cornea has swollen up.
Swollen down,
Yeah.
new endothelium's introduced. What do you expect for a time frame to get back to normal?
It's going to vary. I mean, you should be able to measure the thickness and go back, but that should start coming back by a month's time. That the cornea should be thinning out and starting to level out. But again, it depends upon, as those cells are spreading out, how many of those cells are spreading out into that peripheral area too.